So here comes the fun. Let's look at some compromise results. And the categories are very similar to the previous categories we looked at in terms of what the considerations are. Do we have compromise results sometimes when we go in one of the roots versus the other? Do we have compromise results sometimes when we place the tooth intraradicularly? We have a different set of challenges depending where we position the implant. Let's look at some examples. I think this is an important one. We are going to place the implant mid-root. But we're going to have problems with gaining initial implant stability. This was a molar that you can see the fracture on the occlusal surface. It ran all the way down the root. That's why we had to take it out. We have a fused molar in this case. So basically we have a big hole, a big extraction socket space. There's no interradicular bone. And with standard narrow diameter implants of 6 or less, and this is the drill for a tapered implant of 6 millimeter diameter, 16 millimeter length. As you see in my letter on the considerations and suggestions, I say that this case was quite difficult to achieve stabilization. In fact, the implant was not very stable. And in fact, this was a big problem with any implant. And you'll see that we did restore the case, but that's not the implant I placed. I.e., that first implant failed. And it failed because, in my opinion, we did not have good initial stability. It turns out we let it heal, and we replaced it with an implant in a healed site. So initial stability is absolutely a prerequisite for successful osseointegration, and that can sometimes be a challenge. Other times we can get an implant in the interradicular bone, but we have to keep it narrow because we don't want to take all that bone away and then we'll have no stability unless we have larger size implants. Problem is when we have a narrow implant relative to a big molar tooth, we have a discrepancy in what some people call tomato on a stick. So here's a tooth we're going to take out. There's the mesial and distal views of that extracted tooth. You can see we have some interproximal bone to work with, but the diameter of the implant is relatively small relative to the size of the occlusal table. So we get this emergence profile issue of, as I say, what some people call tomato on a stick. Here's another example of that. So wouldn't it be nice if we could get in a much larger diameter implant, perhaps 8 to 9 millimeters, where we don't have this problem with the emergence profile? But back to the narrower implants, what about when we go into one of the roots with one of these narrower implants? Then we have other problems with compromised position. Now this was a case I showed you previously. That's a healed site placement, but one that we had narrow width orofacially, a lot of room mesiodistally, and we ended up doing 2 implants. That increased patient cost and frankly made oral hygiene more difficult. Well, what if we took out a molar tooth and put 2 implants immediately, one in each of the mesial and distal roots? It's probably going to be a disaster because it's going to be next to impossible to parallel them, and it's rare that you have enough mesiodistal space to be able to restore that properly. So I'm going to show you a very embarrassing case where I did place the implants, I didn't do the restoration, and you can see how this is certainly not what you want to see in your cases. I'll take that one off the screen very quickly. So here's a case where we're going to remove a molar here, the first molar, and we've placed the implant in the distal buccal area, and you can see again compromised implant position, perhaps clinically acceptable, but perhaps not ideal when we're doing placement right into one of the existing molar roots. Not a bad result, but again, you saw this in the intro. This works, but perhaps we have food impaction on the distal. Biomechanically, there may be some considerations, although with an implant this diameter, I don't think it's critical, but maybe not the best we could do. I'd rather see this implant placed mid-root than in one of the roots. And I show you this can get worse. Here's another example. I'm going to place an implant in the distal root here, and you can see that the angulation is much more significant. Now look what happened when the dentist called me up and said they couldn't get the crown seated. And look at the distal contact of that crown, and look how that molar has been adjusted or shaved to try to allow seating of this crown. So this is related to the path of insertion and the fact that the implant is not in the mid-root area with a straight emergence profile. Now, I think part of the problem here, too, is the dentist may have done a one-piece crown and abutment construction or UCLA type of restoration, whereas if they did a separate customized angled abutment and a separate crown, this problem could have been avoided. But certainly the angle of the implant was at least partially to blame for this situation, and eventually the case was modified, but we don't like to be knocking off the mesial aspects of our adjacent teeth to get our crown seated. Here's that case clinically. Well, again, there's a specific situation that we may not come across too often. Here's another case I did more than 6 years ago with the implant in the distal root. And it worked out fine, but actually if you look carefully, you'll see there's a little retained mesial root tip. Now, if we're using one of these large implants that I'll introduce to you in a moment, basically drilling out the interradicular bone, we'd be able to remove that root tip just through our osteotomy procedures, and that would be a nice advantage to get rid of root tips. In this case, it didn't matter, but sometimes we have root tips that may come back to haunt us. Other concerns when we're using the narrower implants in the mid-root placement is sometimes I do get concerned that the amount of space we have between the extraction socket and that implant is quite large, and that can impact on perhaps having a problem with the implant in terms of bone loss, or maybe we tend to sink the implant too far apically because we're worried about the size of that peri-implant void. Here's an example of a submerged deciduous molar, and you can see we have a fairly large peri-implant void, and we're using a standard 4.1 millimeter diameter intraosseous implant with a 4.8 occlusal surface. And the clinical result looks not bad, but when we look at the case radiographically, we'll see what the problem I'm getting at. We have the submerged deciduous tooth. Now look at when I place the implant, and there is already a 3 millimeter healing abutment on this implant. You'll see because of that wide peri-implant void, I tended to sink the implant a bit too far apically just to try to get to a narrower portion where that peri-implant void would be reduced somewhat. And while the implant did integrate well, we pay for it in pocket depth. As Carl Misch likes to say, how deep do we place the implant? As deep as necessary for aesthetics, but as shallow as possible for health. So the deeper we're going to sink our implants in, we don't have to worry about metal showing, but we will get more pocket depth, and we pay for it on the health side of things. I also get concerned with maybe sometimes we're getting a little more bone loss when we have a smaller implant in a huge extraction socket. So on occasion, not too often, we'll see an implant that integrates well, but we may see bone loss down to the second thread, and sometimes I am a little concerned that long term we may be getting over 5 millimeters in pocket depth sometimes around these implants. So let's move on to something that you may not be familiar with, and that's utilizing these, I'll call them MAX implants from the Southern Implant Company, that they make implants of 8 to 9 millimeters in diameter that are specifically designed for immediate molar placements. And this is, again, a slide I showed you before, and you can see via the little diagram that these implants are tapered. They come in 8 and 9 diameter, and they come in 3 lengths, 7, 9, and 11. So let's look at some of these cases, and one of the issues you might ask is, well, when we do these immediate placements in general, should we submerge or can we do them as an exposed protocol or one stage? Most of the ones that I do are in fact immediate one-stage surgical protocol with the transmucosal healing abutment being placed right at the initial surgery. This is wonderful from the patient's viewpoint. They are told, we're going to give you local anesthetic one time. We'll do the extraction, the implant placement of the abutment, and 9 times out of 10 or better, we can do all that at once, and therefore you will not need any further local anesthetic for the balance of all your surgical follow-ups and your restorative procedures. We should not underestimate the power of that, and patients love it, and subsequently, we love it too. On occasion, I will submerge. Here's a tooth we had to remove. So if you've got a fairly large peri-implant void, you can handle this in a number of ways. You may want to graft and even put a membrane on this, release the tissues, and get primary closure. So on occasion we will submerge. I did in this case, and there's a result of that. We never end up needing ridge laps with these wide diameter implants. Here's a different case again. That's this case, sorry. Here's the radiographic story. Submerged with initial placement. Now we get initial stability here with the circumferential lateral bone contact. we don't worry about apical stability. So we're generally going short of the apex of the extraction socket. We want these implants to be a couple of millimeters lingual to the facial bone, and we like them to be usually submerged a couple of millimeters on the lingual or interproximal bone. And this is showing you that case 3 months after restoration. So this is a 9 millimeter length implant by 8 millimeters in diameter, and even if it was 7 millimeters long, I'd have no concern about crown to root ratio or surface area because of the width. Let's look at the way I do it 9 times out of 10. We do it as a one-stage surgical protocol. Let's look at a mandibular case. Here is prior to extraction. We routinely do atraumatic extractions, as we do with all extractions where we want to place implants. We want to preserve the circumferential bone. Here's what the osteotomy can look like just prior to inserting our implant. And again, we want to keep that implant, as I mentioned, lingual to the facial bone and a couple of millimeters subcrest. Here it happens to be taking an implant that's 9 millimeters in diameter and 9 millimeters in length out of the vial. You can see it comes with a pre-attached implant mount. And you see the general positioning here. Here, this happens to be an external hex platform. These implants come with a Straumann-type wide-neck prosthetic attachment, or it comes with a Nobel Biocare-like replaced trilobe type of attachment. I'm showing you the cases where I have a longer-term follow-up, and I started with the external hex. I am now using the IT version, which is the Straumann-like wide-neck attachment. But we're talking surgery here, not so much prosthetics. Here, again, I'm doing a one-stage surgical protocol, placing this 4 millimeter tall healing abutment. You can see where we are relative to position to the soft tissues, about 3 to 4 millimeters, subgingivally, through the platform of the implant. Now, sometimes the soft tissue closure is not perfect. Do not be alarmed at a couple of weeks if you see a little bit of soft tissue cratering interproximally. With good home care, routinely with time, this fills in nicely. You see we've had a bit of tissue recession as we would normally expect. Our 4 millimeter implant is now perhaps showing close to 2 millimeters supragingivally. And here's routinely what the health of the soft tissue looks like when you remove the healing abutment and you're ready to commence your prosthetic procedures. I like to wait on average about 4 months just to be on the safe side. We don't rush things. When I explain to patients, if you want to play it safe, we'll wait longer. I yet to have a patient who says, no, I want to take a risk. I want to restore this right away, or I want to restore this after 4 weeks. An extra couple of months out of their life to play it safe doesn't seem to be an issue, at least in my practice. So there's that case restored, and again, what we find with these cases compared to the narrower diameter implants for single molar restorations is that we never seem to require any ridge lap. We seem to have a better emergence profile. We have smaller interproximal spaces, and we often have patients complaining with narrower implants that they love their implant, but they do complain about the nuisance factor of interproximal food impaction. So we get this much less with these wider diameter implants. Here's that case radiographically, showing you again the implant at 6 weeks and showing the final case 6 months after restoration. And you see these implants incorporate a platform shift or a platform switch, and this is that 9 long by 9 wide. Let's look at another case. Again, we remove the tooth atraumatically. Here you get a good idea of the implant positioning. We're a couple of millimeters subcrestal on the lingual and interproximal. Very often on the buccal, we're not 2 millimeters subcrestal. So there's always some scalloping. Patients rarely present with bone that's perfectly flat. Here you get a better view showing the relationship where we are 1.5 millimeters lingual to the facial bone. We're not fully 2 millimeters subcrestal here. This void probably would fill spontaneously with good soft tissue closure, and by that I don't mean necessarily submerging the implant. I include sealing the tissue around the healing abutment as soft tissue closure. And our colleague, Dr. William Becker, or Bill Becker, used to call this getting a seal, but he called it a fibrin seal of the soft tissue to the healing abutment. We usually do graft these sites, mostly because perhaps we feel better if we can graft that, but we charge the patient very little for this very minor graft, and almost anything will work because this is a very predictable grafting situation. So the cost of this graft is 1/10 of what it might be if you were doing a separate extraction socket preservation. So there is a good cost savings as well as time savings to the patient, and of course you're saving them at least an extra surgical procedure. So here again, transmucosal healing like the previous case. We remove the healing abutment once again. This is an external hex showing excellent soft tissue health. This implant's 8 millimeters in diameter. The previous case was 9. But again, we're getting this kind of results pretty much on a routine basis with this design. And here's that particular case. And again, there's still some remodeling of the graft that we place, you can see radiographically. Well, the maxilla is no different. Here's a case, and again, routinely trisecting the maxillary roots, removing things atraumatically, one root at a time. You can see here the floor of the sinus. We have a fair bit of bone to work with here. We have other cases where we have far less, where we can still manage. This happens to be only 7 millimeters in length, 8 in diameter, at the time of initial placement. And here, 4 months later, you see the bone remodeling and the final restoration. And here you can clearly see the platform shift we're talking about, and just a great service for the patient. Here's that same case clinically. Again, what it looks like with the healing abutment removed, and the facial view, and the final view. But every system sometimes has some little challenges, and it wouldn't be fair and honest if we didn't include some compromised results with this particular implant design. And this again can be categorized. You see I've got 4 categories there. So let's look at just a few examples, starting off with the problem with unseated abutments or lost abutments. Because on this particular implant design, and this is the external hex system, 9 millimeter diameter, where the specific contour of the healing abutment bevels out, on occasion we impinged on some of the bone, especially if the implant was placed subcrestal. This wasn't a big problem. We could remove the bone judiciously, or just at the post-ops, tighten that healing collar, because that bone, interfering bone, would actually slowly resorb under the pressure of the healing abutment. So not a huge problem, and frankly I think this was more of a historical problem when I used the external hex implants, and I haven't seen this problem now that I've gone over to the Straumann wide neck type. Again, those are called the Max IT implants. We've even seen on occasion in the final restoration where the definitive prosthesis was not fully seated. But I also like to show this case to show you how even here, look at the floor of the sinus. We've got barely 6 millimeters of bone here. Yet we can do this case with an immediate max implant without sinus grafting. We can just bump up the floor a little bit with that smooth dome on the top without tearing the Schneiderian membrane. This is a 7 millimeter length implant, 9 in diameter. You can see this implant is almost like a ball when you get to this size. And I would caution you that when you place this implant, if you go after you've used the handpiece placement and you want to turn it slightly more with your wrench, you do need to be careful that you don't change the orientation of the implant. Again, you're not dealing with a deep, narrow osteotomy where there's no way you're going to change the orientation. But in a case like this, where you do not have complete congruency with the bone all around the implant, and you've got an implant that's more like a ball and less like a long, narrow one, if you're not careful, you can actually turn the implant slightly, and I think I did that in this case. So you can learn on my experience, because I knew when that implant went in with my handpiece, it looked perfectly straight to me, yet in the final analysis, it ended up being slightly tilted. Here you see the healing abutment on. But I like this case from the point of view of how we managed with very minimal available bone. But you can see even in the final prosthesis, the crown on the mesial does not look fully seated, or the abutment actually. I think this is similar to that lower molar case I showed you where we were in the distal root, where the dentist may have used a one-piece implant and abutment and had difficulty with the path of insertion. And I do believe this could have been corrected with a 2-piece system, a customized abutment to correct the angulation, and a separate implant crown placement. But again, the angle was off a bit, and I do caution you not to change the orientation, especially if you're going with the wrench after your handpiece placement. This is something that's anecdotal. Is there a concern of having two large implants placed right next to each other? Going back historically when wide diameter implants were introduced, and early on some people were reporting on higher incidences of crestal bone loss, one of the theories for that was that the implant itself is in effect an avascular object that you're putting in a patient's alveolar ridge that interferes with the patient's blood supply. And after you put that blob of avascular titanium in the bone, the body must reform its blood supply and reform a collateral circulation around that. So the bigger the implant, the more challenging it is for the body to heal, and perhaps if you thin out the bone a bit much, you can have bone loss. Well, what if you put two avascular objects, very large ones, next door to each other, even if they're 2 or 3 millimeters apart? Perhaps that's a challenge to the healing process. So for now, we are recommending that if you're using these large implants, do not do two adjacent large max implants unless you're separating them, in my opinion, by 4 millimeters or more. I'll show you just two cases to demonstrate this. These two molars had to be removed, and I did place two adjacent max implants. The mesial one is 9 diameter, the distal one's 8. But even after 5 months, we had a challenging healing of the soft tissue. A case of one does not make a scientific study, and actually the bone looked very good. And we actually have not been able to get this patient back for follow-up, as is a common problem as a periodontist. Once they have their implants restored, they don't want to see me anymore. So, but in speaking to others, they've agreed that this is something that if you're going to do two adjacent implants, as in the second case I'm showing you, try to spread them apart further if you can. Otherwise, I would do them one at a time. Let one heal, let the blood supply reestablish, and then do the second. In this particular case where the implants were further apart, again, you see there's no challenge, no compromise in the soft tissue healing. Another bit of my learning curve is I tend to look to the 8 millimeter implant as my default implant and only look to the 9 millimeter implant if I'm sure I have the bone available for it. So I think that in the beginning when we use wide implants, we sometimes get too aggressive and maybe go with a 9 when we should have gone with an 8. We end up maybe thinning the bone a bit, maybe compressing on the bone a bit. Then we end up getting some bone loss, recession, and maybe a little implant exposure. So let me show you a case where I did this. Here's this second molar we need to remove. You see the radiograph here. We've got lots of height, so I'm going to put in a long 11 millimeter implant, but it's 9 in diameter. And in hindsight, I would have gone with an 8, because this is the buccal view, and you can see the gray metal showing. Part of that first level of gray is the abutment, and the little line of gray closer to the tissue is actually the top of the implant. And palatally, similar situation. Now, is this a concern for the longevity of the implant? I doubt that it's a concern. Is it a cosmetic issue? Obviously not. But certainly, I think we should try to avoid this. So again, I don't often go to the 9s. They're there for the odd case. What about malposition of implants? I already alluded to mesiodistal malpositioning with those short, fat ones that with the ratchet, if you're not careful, you could perhaps reorient. Apicocoronally, let me show you a case where we needed to remove this tooth. And as you look at this initial placement, it looks pretty good. Certainly on the mesial, we're well below the interproximal crest of bone, but we have a big discrepancy on the mesial interproximal bone height level and the distal. The distal is much more apically positioned. So on the distal, we're just barely at crest. This is the day of implant placement. Let's see what it looks like as we follow it up. We're getting a little bit of bone remodeling, and now we have a thread exposed, even after 6 weeks. And when we look at it 4 months later, we have almost 2 threads exposed on the distal. And when we look at it 5 months after restoration, we've stabilized at the second thread. Not a huge issue. Don't think it will impact the long-term prognosis of the implant, but be aware that we want to try to get the implant usually 2 millimeters subcrestally on the interproximal and lingual aspects or palatal aspects. Typically that means you're not that far below crest on the buccal in most situations. Here's that case clinically that looks fantastic, but again, radiographically it was imperfect. So in summary, with immediate implants in general, in all areas of the mouth, I think we can confidently say that based on the evidence in the literature, certainly based on my own experience, they definitely can work. Of course, you need to do your case selection properly. If you've lost your facial plate of bone, I would not consider that a good case. We want the circumferential bone intact, for example, no huge periapical lesions, and so on. What are the advantages of immediate implant placement? I cannot overemphasize the importance of increased patient acceptance. Patient and dentist really both benefit, and I even think that you can get improved clinical results. In terms of specifically that Southern Max implant, I do think this design offers some unique advantages, but there are some unique precautions as well. The unique advantages is that with the molar extraction sites, we can more predictably get initial stability, fewer cases that you'll have to abort due to lack of initial stability. And that aggressive taper, I think, is well designed as well, because as we go apically, for example, in the posterior molar, we're into the mylohyoid lingual undercut, and we have less risk of perforation through the lingual cortical bone. Because we have such a large diameter implant in what is a pretty large extraction site, we have a smaller peri-implant void compared to using a narrower diameter implant, and I think this reduces the amount of grafting we have to do. It reduces the number of times we have to submerge and do a two-stage surgical protocol, and it reduces the need for releasing incisions to get a decent soft tissue closure, even if we're doing a non-submerged protocol. I do also believe the wider platforms of 8 to 9 millimeters in these molar sites do improve biomechanical stability because we have a larger prosthetic table. We can incorporate a fair degree of platform shifting, and many of us feel that that can reduce crestal bone loss because we're taking that micro gap, moving it away from the bone, and moving it on top of the horizontal prosthetic table. And lastly, again, to summarize, there are some precautions that are specific to this design. We do need long-term studies. We do have to make sure that we stay lingual to the facial plate of bone. We want to perhaps not be too aggressive with the 9s, as I mentioned. The 8 is my default. The 9 can be a rescue or just salvage for very select cases where we know we have lots of room. As I mentioned, be careful with the orientation of your small, round-like implants if you're going with the wrench. Like any implant, be careful not to over-torque with the wrench because you can strip the thread. This can happen with any implant, but sometimes with the short, wide implant, especially if you don't have circumferential bone congruency, it might be a little easier, so don't overdo it on the torquing. And other things that are, I think, for any implant, if you have significant bone defects, if you have narrow ridges with total lack of keratinized tissue, those are issues you have to be on the lookout for. So again, my name is Murray Arlen, full-time periodontal practice in Toronto. Want to thank, again, Dental XP for allowing me to share this presentation with you. And as I mentioned, it's the second one we've done. The first one is actually on narrow diameter implants. And again, you can access that in the archives. Thank you for your attention, and I hope you enjoyed the presentation. Bye-bye.